Okay, so I tried to make this kind of like basic yet advanced. So if anything is like too basic or over your head, just let me know. Um, so like I said, I'm a nurse practitioner. I work in endocrinology. I'm an FNP though, and I work inpatient and outpatient. So I usually have, oh great, this is gonna do this. Hold on one second. I don't want it to change without me telling it to. And so, I'm a family nurse practitioner, but I work in the hospital and then also outpatient clinic. So I kind of do a little bit of both. So just a few things to go over real quick. When I'm talking about some things, I want to make sure they make sense. So I don't know why my timer is doing this. Hold on. So when I talk about basal insulin, I'm talking about long-acting insulin. And prandial insulin is your short-acting that covers meals and does your sliding scale. Basal bolus regimen, when I say that, I mean that's the combination use of long and short-acting insulin together. So like when you're talking about a full insulin regimen for a patient, usually we call it a basal bolus regimen. And then the term CGM refers to continuous glucose monitor. So this is like your Freestyle Libre and Dexcom that you wear on your arm, and it gives you a continuous reading of your blood sugars. An insulin pump is a device that's used to deliver insulin based on program settings. TDD is your total daily dose, and this is for insulin. And you need to be able to figure out what your total daily dose is for when you're dosing insulin to do your prescriptions, because the pharmacy always asks for it. And then AC means with meals and HS is with bedtime. So this is just kind of a picture that I kind of wanted to share. I mean, it could be basic for you guys, but this is something that I kind of had a hard time grasping when I was in school. So when you're doing insulin, you have a long acting and you have a short acting, because normally people have both, and we're trying to mimic how patients like intrinsic insulin production is. And so you have a basal insulin, which lasts for generally 24 hours, unless you're using NPH. NPH down here is 12 hours. But you basically want this long acting insulin to be on board, be stable throughout the day. And then you want to use short acting insulin to cover your food. So this is going to be Lispro or Aspart or Novolog and Humalog or Admelog. But basically, I like to show this because this is why giving somebody just long acting insulin isn't helpful. So if you give somebody only Lantus, Basaglar, one of the long acting insulins, and you don't give them anything else to cover their food, then every time they have one of these food spikes, it's not going to cover it. So basically, like if I just put somebody on Lantus and I keep going up and up and up, I'm trying to cover these food spikes ineffectively. And then overnight, while it's still active, if you're at a really high dose, your patient will go low because it's too much insulin. So that's why you really need the two different types to actually cover what needs to be covered. So when you're talking about glycemic goals in these patients, so when you're first diagnosing somebody with diabetes, pre-diabetes is an A1C over 5.7, and diabetes is an A1C over 6.5. So this is just when you're first diagnosing somebody, and you need to, you're looking at their A1C and you need to decide if you need to treat them or not. People with prediabetes, it's kind of up to you. Usually you can start with just diet counseling. Sometimes we'll start them on metformin, but you don't always have to treat prediabetes. It's just something the patient needs to be aware of. And then obviously once you get to an A1C of 6.5, you need to start treatment. One thing to remind your patients of is once they have diabetes, they have diabetes. So you can control it, but you can't cure it. The exception to that would be gestational. Gestational diabetes is going to, if it's truly gestational, it's going to go away after pregnancy. And then once you start treatment on these patients, your goal A1C is technically 6.5%. This is hard to achieve. And so in the real world, if a patient has an A1C less than 7, you should like give them a party because it's a big deal. But you also need to pay attention because if they're on an insulin regimen and even if they're not, if their A1C is less than 7, honestly, you need to make sure they're not having low blood sugars because sometimes their A1C is like 6.2, but then when you look at their meter download, they're having like frequent lows in the 60s and 50s. So you really have to make sure that it's actually good control and it's not just low sugars all the time. Technically, a fasting glucose goal is 110 to 140. So sometimes when you're like having somebody titrate their dosing, that's kind of your goal that you're looking for when they're first waking up is about 110 to 140. And honestly, in real life, as long as somebody's not less than 70 and not greater than 200, that's pretty great. Blood sugars in the hundreds make me happy. So types of diabetes, we've got type 1, where you have absolutely no intrinsic insulin production. You've got type 2, where you have normal insulin production, but you are resistant to that insulin that's present in your body. Gestational is only present during pregnancy and resolves after delivery. And gestational is more of a glucose intolerance. So it's not, I wouldn't say that it's like exactly the same as diabetes. It's really its own thing. And basically, you just have high postprandial blood sugars usually when you have gestational diabetes. And so it's treated a little bit differently. And then diabetes due to pancreatic insufficiency, this is a lot more common than you think. So I see this a lot. I see it in the hospital a lot, but that's because I see a lot of patients that have had pancreatitis episodes or pancreatic surgeries or something. But they also get referred to me too. And we'll go over, I have a whole slide of pancreatic insufficiency stuff, but it is pretty common actually. And then, you have your type 1.5, LADA, MODY. These are all complicated and we won't cover them today. And really just let your endocrinologist take care of that. So with type 1, insulin's your only treatment. Every now and then you'll see a patient that's on like metformin or a GLP-1 like Victoza or something like that for weight loss, but it's very uncommon and it's not for glucose control. So if you ever see a patient that's a type 1 and they're on one of those meds, it's not for their blood sugars, it's for other reasons. So type 1 has to have insulin because they don't make any. Typical symptoms of like a new diagnosis of type 1 diabetes is going to be polyuria, polydipsia, and weight loss. And this is pretty common scenario. So a lot of patients that come to see me who are a new diagnosis, I ask them, well, what was going on? And they're like, well, I was peeing all the time. I was really thirsty and I lost like 20 pounds in a month. So that's a pretty common set of symptoms. Now with these patients, they have to always have a long-acting insulin. So, and again, that's a basal insulin. So let's say worst case scenario, let's say your patient is a type 1 and they're not eating all day long. If they skip their short-acting insulin, they'll be okay. But if they don't take their long-acting insulin, their basal, then they could potentially go into DKA. So they have to have that long-acting insulin on board all the time. So even when a patient's in the hospital and they're really, really sick, we'll still give them like 2 units of Lantus just to make sure that they always have basal insulin on board because they're not making any at all and they can easily go into DKA. When you're writing prescriptions for a type 1, you should include ketone strips and emergency glucagon. So ketone strips is for them to monitor their urine for ketones to make sure they're not going into DKA at home. And then emergency glucagon is if they have a low blood sugar emergency. So if it's like less than 40, if they're unresponsive, that's something that their family member needs to be educated on, and they need to use that if the patient's not able to treat themselves for a low blood sugar. And then with type 1, these patients' blood sugars are usually very variable. So even when you've got somebody on the perfect regimen, they're still going to have highs and lows. It's just normal and natural, and it's really hard to prevent. With that being said, they can definitely benefit the most from pumps and CGMs. And so, some type 1s don't want to be on that. They'd rather do injections, but a lot of them are going to be on a pump because with a pump, you can really tailor everything. Like you can almost do a setting for every hour if you wanted to, which is usually not necessary, but it's very, very tailored to that patient. And so it's really helpful. So pancreatic insufficiency, when it's severe, these patients are going to be like a type 1 because they're basically not going to be making enough insulin to function. And one thing that can cause this is long-term use of sulfonylureas. So, a lot of people will use glipizide, glyburide like pretty frequently. We don't use them a lot unless people have cost issues because there's other issues with them. And one of them being this, that they can cause islet cell burnout. And so if you have somebody that's been on a sulfonylurea for a really long time and suddenly their blood sugars are crazy out of control, they're having a lot of issues, or they get admitted to the hospital in DKA, definitely something to look into. And then patients that have had surgical interventions on the pancreas. So if they've had a Whipple surgery, if they've had a partial or a full pancreatectomy, or a TPATE, which is a islet cell transplant. So TPATEs we do in our hospital, and it's a complete removal of the pancreas, but they harvest the islet cells out of the pancreas and they re-inject them into the patient with the hope that the islet cells will survive and keep producing insulin. It doesn't always work. And I see a lot that fail, and the ones that fail, they're super, super brittle diabetics afterwards. But when it works, it's better than having a pancreatectomy with no islet cell transplant. So, but it's tough when people get to that point anyways. And then obviously just chronic pancreatitis. So anything that's affecting the pancreas is affecting your insulin production. And so if you have a patient that's in any of those situations, or if they're just not responding to PO meds, or if they have any history of a hospital admission for DKA, or even if they just don't look like a typical type 2. So they're like really thin, and they just don't look like somebody that you would normally see as a type 2. You can always check a C-peptide. And a C-peptide is a lab test, and it gives you an estimate of how much insulin the patient is making on their own. So we do this all the time, and it's a super easy thing to order. All you do is you just order a C-peptide, and you order it with a concurrent glucose value. So you want to check a C-peptide with a blood sugar at the same time. So when you order this lab, you order that C-peptide and order a serum glucose at the same time. And so the reason why you do them at the same time is that you can affect your results validity. So if your glucose is high, the C-peptide result is stimulated, so it could be falsely elevated. However, if the glucose is high and your C-peptide is still low, then they're definitely deficient in insulin. If the glucose is low, the result's not stimulated and can be falsely low. But basically, if you have a C-peptide that's less than 1.0, they're definitely deficient in insulin production. Now, you may not need to start them on a full insulin regimen as soon as they're like 0.9, but if they're like 0.5 or less, you really should treat them like a type 1 diabetic. And this is something you could always refer this patient out. But if you get a C-peptide first, you'll kind of know, do I need to refer this patient, or can I still keep treating them as a type 2? And then gestational diabetes. So these are patients that have no prior history of diabetes. It's detected through oral glucose tolerance test in weeks 24 to 28 of pregnancy. You can do a 1 hour, usually they'll do a 1 hour glucose tolerance test. And then if you fail that, they'll do a 3 hour test. With gestational, it resolves post-delivery. However, they have a very high risk of developing type 2 later in life. So that's something that if you have a patient with a history of gestational, you should definitely have them follow up with their PCP and get regular checks to make sure that they're not becoming a type 2 later down the road. And then if you have an established diabetic patient find out they're pregnant, they really need to be on insulin. So there are studies that have shown you can continue metformin, but the safest thing to do is put these patients on insulin or refer them to endocrinology. In pregnancy, just an interesting thing, I'll show you this graph here. Your insulin requirements in pregnancy climb dramatically, and then they drop off as soon as you have the baby. So right at the very beginning, the insulin requirements actually dip a little bit, which is weird, but then they just slowly climb. And then as soon as you deliver, they usually decrease in half or more. In patients who are breastfeeding, their blood sugars run lower as well. So it's just kind of something to be aware of. Type 2, obviously most common. This is what we see all the time. Metformin is still the first line treatment for type 2 diabetes. If you're starting metformin, always make sure their creatinine is normal. So always check a BMP. You want to titrate this slowly to avoid GI distress. So the biggest complaint everybody has about metformin is diarrhea. And so if you can start it low and increase it very slowly, usually they can tolerate it better and they're not going to say, oh, I'm never taking that again. If they can't tolerate even just 500 milligrams daily of the immediate release, always try extended release dosed at night first. And you can dose extended release just the same as immediate release, like max dose of metformin extended release is 1000 BID, just like immediate release. So even though it's extended, you can still dose it the same. And so the extended release is generally better tolerated with the GI side effects. So usually if patients come to me and they say, I can't take metformin, it gave me diarrhea, I'll usually try to get them to try it one more time with a lower dose and extended release. And then other agents, SGLT2s and GLP-1s are the preferred choice for second agents. So, and then if you have cost issues, you can use the sulfonylurea. We really don't use Actos at all. It's really just not recommended due to risk of CHF or exacerbation of CHF, and also a risk of bladder cancer. So honestly, we just don't even use it. Usually when patients come in on it in the hospital, we just usually end up getting rid of it and replacing it with something else. And then something that you can tell your patients, when they're really just, you can't get them under control and you know that it's dietary, insulin causes weight gain. Just the way it works, it causes weight gain. And so it can be a motivating factor in getting patients to get under control and not start insulin if you tell them this. And then you can also use DPP4s, but generally they're pretty neutral when it comes to any added benefit. So that's why we usually like the SGLT2s and GLP-1s better, because they have other benefits. The DPP4s are just kind of like, yeah, it works, but it doesn't really give you any other extra help. So the GLP-1s, this is going to be Trulicity, Victoza, Ozempic, Bydureon, and the new one is Rybelsus. So all of them are injectable except for Rybelsus, which is a pill. And the Rybelsus, I'm sure, will be very popular, but right now it's hardly covered. So we don't really prescribe it yet, but I'm sure I will be doing it a lot more in the future because everybody would rather take a pill than an injection. And it activates glucagon-like peptide 1, which increases insulin secretion. It decreases glucagon secretion, and it delays gastric emptying. So with that being said, it's contraindicated in patients with gastroparesis because it delays gastric emptying. So if you already have a patient that has impaired gastric emptying, you wouldn't want to give this to them because that can really screw them up. And hold on one second. I'm just going to pull up the chat box just in case you guys need to interrupt me. Okay. And so gastroparesis is a no-no. If they have a history of pancreatitis, you can't use these. If they have a history of thyroid cancer, this is kind of like a label situation where they had osteosarcoma, thyroid cancer in rats, but it really hasn't been shown to be an issue in humans, but it is a listed side effect. So if somebody has active thyroid cancer or like a really strong history, you may want to steer clear of these. And then if you have a GFR less than 45, probably not great. But honestly, once somebody has renal disease, like significant renal disease, all you can really give them is insulin anyways. So all of these are going to have some renal dosing component to them. And when you're starting these, so obviously all the drugs are expensive. They're all expensive except for metformin and sulfonylureas. So when you're starting these, you can pretty much just pick one, but most insurances are going to prefer one of them in this class. And so like, let's say you prescribe one for your patient and they're like, oh, they told me it's going to be $500. You can tell them to call their insurance company and ask which of these in this class they prefer. So the patient can call and say, which GLP-1 do you prefer? And they'll usually have one that they would choose, and that'll be better covered for the patient. Ozempic, Trulicity, and Bydureon are dosed weekly, which is usually preferred by patients. Victoza is very effective, but it's dosed daily. So a lot of patients would prefer a weekly versus daily injection. And then, like I said, Rybelsus is the pill that we're not using a whole lot yet, but I think it'll be used a lot more in the future. And the benefits of these are weight loss, and they have a cardioprotective component to them, so they can help protect you from coronary artery disease. And when you're starting these, warn patients that after they start the medication, when they're eating, don't push past the feeling of fullness, because that's when they start to feel nausea. And that's usually like the most noticeable side effect with these. It's not super common. Honestly, most of my patients tolerate it really well, but if they kind of overeat, then that's when they're going to have problems with these. SGLT2 inhibitors. So the long explanation is that it inhibits sodium glucose cotransporter 2, which reduces glucose and sodium reabsorption. And overall, it increases urinary glucose excretion. So these work well. They make the patient pee out more sugar. And this is going to be Farxiga, Invokana, Jardiance, and Steglatro. And they're contraindicated in patients that have frequent UTIs and yeast infections, as well as urinary retention, just because of the fact that it increases sugar in the urine. So obviously, if you have, these issues frequently, and then you put a bunch of sugar down there, it's going to cause a problem. So it can be used in patients with chronic pancreatitis. This is one of the few drugs you can use in a patient that has a history of pancreatitis. And benefits are weight loss as well, and then CHF and CAD risk reduction as well. Recently, I've been seeing cardiology using these for heart failure treatment and not diabetes, which is interesting. But they've shown in some studies that these are really good for heart failure treatment. And so, if you see it on your patient and you're like, wait, they don't have diabetes, it might be because of that. But it's also something to consider if your patient does have CHF. You might want to choose this over anything else because it can be really helpful. And then sulfonylureas. So they work by stimulating pancreatic islet beta cell insulin release. So basically, these medications just make your pancreas produce more insulin. And that's why they can cause burnout, because they're just constantly stimulating the islet cells to produce more insulin. So this is glipizide, glyburide, glimepiride, and glucotrol. The one I always use is glipizide, so I always end up just saying that over and over, but obviously there's other choices besides glipizide. These are contraindicated in pancreatic insufficiency. So the patients that aren't making enough insulin, you don't want to try to force them to make more insulin because it's really not going to work. If they have renal or liver impairment, And you need to be cautious in the elderly or with patients at high risk of complications from hypoglycemia. So this can cause low blood sugars because you're just stimulating the pancreas to produce a bunch of insulin. So if the patient's not eating frequently, then they're probably going to have low blood sugars. So with that being said, it's not good for patients with a poor appetite or a very variable eating schedule because if they just take it and don't eat, then they're going to be low. So in general, a sulfonylurea plus an insulin is not something that you would normally do. However, in some situations, you can use a low dose sulfonylurea as like your prandial coverage. So your short act, like in replacing your short acting insulin, basically. So you could technically do a sulfonylurea and a basal insulin. So this would potentially, your basal insulin would cover your long acting insulin needs, and then your sulfonylurea would cover your food spikes. The benefits of this is that they're cheap. And when you're dosing them, always try to keep your dosing as low as possible. So with glipizide, I usually do 2.5 to 5 milligrams once a day or twice a day. But really when you get up to 10, 15, 20, it's kind of unsafe. And when you get up in those high doses, it's probably not that effective anyways. So starting insulin. You can start insulin if you're not at goal on triple therapy. If you have pancreatic insufficiency and you have to start insulin, or you have a new type 1 diagnosis. So if you're starting insulin on somebody who's already on oral medications, you're going to start with a basal insulin. Obviously, if you have a type 1 or pancreatic insufficiency patient, you've got to be on long and short acting basal bolus insulin. But if you just have a type 2, they're on other meds, you can start with a basal insulin. And so where to start? Weight-based dosing, a safe place to start is 0.2 units per kg. If you're nervous, you can always start with like 10 units. That's kind of a safe dose for most people. So like, let's say you've got a patient on metformin and Victoza and Farxiga. You could start them on Lantus 10 units daily, and it's not going to hurt them, and it should help a little bit get them down. But again, it's one of those things where you can tell the patient, this is going to probably make you start gaining weight, so you might want to get it together. The patient can titrate themselves up by 1 to 2 units daily until their fasting glucose is like 120 to 140. But honestly, like we said earlier, basal insulin alone is not an efficient regimen, especially when you get over like 30 units a day. So when you're using this, you can use it with other medicines, that's fine, but don't just like stop their other medicines and put them just on Lantus and like, that's it, because it's really just not going to work. When you're picking a long-acting insulin, so Lantus, Tresiba, Levemir, and Basaglar are pretty much equivalent.
Can you go back just that slide for 1 second? I just wanted to jot something down real quick. Sorry.
Yeah. Did you have a specific question?
No, I just wanted to write the weight-based dosing. It didn't get it down.
Sure. Yeah, 0.2 units per kgs is usually where I start in the outpatient setting.
Okay, I'm good.
Okay. And so, so Lantus, Tresiba, Levemir, and Basaglar are pretty much equivalent. They have no peak, which means that they're very steady and they're not going to have a peak which could drop the patient throughout the day. So they're good for type 1s who are sensitive, and pretty much anybody is going to tolerate these well. You can see that next to Tresiba, I wrote U100. So Tresiba also comes in a concentrated form, which is referred to as U200. And there's another medication called Toujeo, which is U300. When you see those U200, U300, what it means is that the insulin itself is concentrated. So the reason why you use those is because it's less volume for the same dose. And so patients that are on high doses of insulin, you want to give them a concentrated form because they're basically like, it's like 2 times stronger or 3 times stronger. So if you're going to give yourself 3 units, it's just going to be U100 would be a certain amount of volume. U200 would be a lower volume, and U300 would be an even lower volume for the same amount of insulin. And so the less volume, the better it's absorbed. Some of these patients, when you get them up to like 60 units at a time, their body's just not going to absorb that much liquid at once. So that's why you move to a concentrated insulin. Also, one thing you can consider is if you have a patient that's on a lot of long-acting insulin, before you use a concentrated insulin, which are super expensive, you can try splitting your basal dose and just dosing it twice a day. So like, let's say you have a patient that's on 60 units of Lantus a day, you could give them 30 in the morning and 30 at night. And again, it'll be better absorbed and you don't always have to go straight to a concentrated insulin. But if the patient can absorb a concentrated insulin, it's usually going to work better. If you ever see somebody on U500, this is a totally unique situation and really should be handled by endocrinology. If you have somebody who is requiring like over 100 units of insulin a day, you should just refer them. But U500 is actually regular insulin, which is only on board for 6 hours. And so it's usually dosed twice a day or 3 times a day. And it's a completely different dosing regimen than any other kind of insulin. So if somebody's on U500, it's high risk and it's a totally different situation, and just refer them. But it is something to be aware of because sometimes patients will come in the hospital and people will think they're just on regular U100 insulin, but it's actually U500, which is a huge difference, 5 times stronger. And then your other option with basal insulin is NPH. And so NPH is technically intermediate acting. It's on board for 12 hours and it does have a peak. So we use it a lot with steroids because it works really well with steroids. But other than that, it's not the best basal insulin to choose. It is a little cheaper than some of the other ones. But basically with NPH, you're going to dose it twice a day and it's still going to give you that long acting coverage. And when you're dealing with mixed insulins like 70/30, NPH is the long acting ingredient in those. And that's why you dose those twice a day. I'll cover that later. Using a sliding scale. So you're going to be using your short acting insulins for a sliding scale. So this is going to be Novolog, Admelog, and Humalog. A sliding scale or correction scale is used to treat hyperglycemia, but it's not food coverage. So if all you do is put somebody on long-acting insulin and a sliding scale, you're playing catch up all day long because the sliding scale is designed to only correct what didn't get corrected by the mealtime coverage prandial insulin. So you've got to cover the food with a prandial dose and then give sliding scale on top of it to correct for the glucose value. So if you're going to start a sliding scale on somebody, you might as well start prandial insulin too, because there's really not much point in having one and not the other. But there are situations where, like in patients that are end-stage renal, where the only thing they can take is insulin, their requirements might be super, super low. And so you may put them on a sliding scale and nothing else, but that's kind of an unusual situation. And so a best place to start with a sliding scale is going to be 1 unit for every 50 points over 150 with meals, and 1 unit for every 50 points over 200 at bedtime. So basically what this means is when they check their blood sugar before breakfast, lunch, and dinner, if it's over 150, they're going to give themselves 1 unit on top of their prandial dose. So let's say their prandial dose is 3 units with meals and their blood sugar is 152, they'd give themselves 4 units. But if their blood sugar is, so if you start at your scale at 150 and it goes by 50 points, then your next increment is going to be starting at 200. So at 200, they'll give themselves 2 units, and then 250, 3 units, 300, 4 units, if that makes sense. So basically this is the way we write it, but I know it's confusing. But that's kind of a typical outpatient sliding scale. And then if it's not enough coverage, you can do 2 units at a time. So blood sugar over 150, 2 units, blood sugar over 200, 4 units, blood sugar over 250, 6 units, etc. So that's kind of how you use a sliding scale. But so going back to prandial insulin, so this is when somebody needs full insulin regimen. So they need injections to cover every meal and a long-acting insulin. So so this is going to be pancreatic insufficiency, type 1, or like a type 2 that literally cannot get it together with anything else, and you're just going to start them completely on insulin. If you're starting a prandial insulin on a type 2, always stop your sulfonylureas. So we talked about how you can use a sulfonylurea with a basal insulin, but if you're starting short-acting insulin, you're going to get rid of your sulfonylurea because basically the sulfonylurea was taking place of prandial. And so you're always going to stop those. You're never going to have both short-acting insulin and a sulfonylurea in somebody's regimen. And you're also going to do weight-based dosing to start this. So usually we're going to just do 0.1 units per kg. And so somebody who's 65 kgs, you would start with just 6 units with each meal. If you're nervous about starting prandial insulin on somebody, you can always start with 3 units with each meal. That's like a safe dose for almost anybody. And then technically in a perfect world, if you have a full insulin regimen, you want your basal and prandial to be a 50-50 split. So technically if you have like, you know, let's say, I'm trying to think, do math in my head, but if you were going to give somebody 3 units with each meal, that would be 9 units total of prandial insulin. So you'd want to give them like 9 units of Lantus. So long and short acting should total up to be about a 50-50 split. It's never going to be exactly 50-50, but you want it to be close. The main thing is that you don't want somebody to be on like 40 units of Lantus and then like 2 units with meals, because it's just not really working the way it should. Does that make sense? Okay. When you're titrating insulin, so you want your fasting morning numbers to be technically less than 140 consistently. And when you're looking at your basal dosing, so your long-acting insulin dosing, you're looking at your fasting numbers, because overnight is when your basal insulin is active and it's the only thing on board. And so those numbers when you're first waking up are what is going to tell you if your basal dosing is appropriate. And so if you, and I have an example after this, but if your patient's waking up high every single morning, you're going to want to go up on their basal. For prandial dosing, you need to look at their daytime pattern. So they're getting their short-acting insulin with each meal. And if they're continuously climbing with their blood sugar after each meal, then they're not getting enough prandial coverage. Ideally, basal insulin should not cover food. So if you have somebody only on basal, they'll run high during the day and low overnight, like we talked about earlier. So this is an example. Patient comes to see you, has their blood sugars with them. They're actually checking ACHS and they're on a full insulin regimen. And so this is like 2 days worth of readings. One day they woke up at 82. Then at lunch, they were 165, dinner 235, bedtime 315. So obviously climbing all throughout the day, but waking up pretty tight with their blood sugar. Next day, same thing. Woke up at 79, 189 at lunch, 210 at dinner, 280 at bedtime. Their current regimen is Lantus 25 units in the morning, Novolog 3 units with meals, and then a 1 scale. So 1 for every 50 over 150 with meals and over 200 with bedtime. So looking at this, obviously our morning readings are too low. So you don't want somebody that's below 100 when they're waking up, because that puts them at a lot of risk for overnight lows. So the first thing I would do is back off their basal. So usually when you're making changes, you can make about 20% increase or decrease. But with them waking up at 79, 82, I'd probably back them down from 25 to 20 of Lantus. And then the Novolog, as you can see with each meal, their blood sugar is climbing. So I'd probably go up by like maybe 2 units on their prandial insulin. So I'd probably go up to like Novolog 5 units with meals, go down to Lantus 20 in the morning. And by the way, you can dose your basal morning or night and it doesn't matter. So regardless, it's going to be on board 24 hours. So it doesn't matter if they take it in the morning or at night. Mixed insulin. So this isn't used probably enough. It's actually something that can work well for a lot of people. It's good for patients who require insulin, but are not compliant with basal bolus. It's really hard for patients to do 6 injections a day. And so mixed insulin is 2 injections per day. And so mixed insulin has long and short acting in it. And so you take 1 injection with breakfast that covers your breakfast and lunch, and 1 injection with dinner that covers your dinner and overnight. So obviously it's not the most effective thing you could possibly do, but it has long and short acting insulin in it. So technically you could give it to a type 1, and you could give it to anybody who requires insulin. And so the way you dose it is it's always going to be more in the morning because it has to cover breakfast and lunch. And so the way you're going to basically choose your dose. So let's say somebody comes in to see you and they're supposed to be on, like, let's say Lantus 10 and 3 units of Novolog with meals. And they're probably not taking it. But if that's like an appropriate dosing for them, their total daily dose would be 10 plus 3 times 3, so 9. So 19 would be their total daily dose. So if you were going to put them on mixed insulin, you would take that total daily dose and you would multiply it by 0.7 for the morning dose. So 19 times 0.7 is 13.3. So we just round that to 13. And 19 times 0.3 for the dinner dose is 5.7. So let's say 6. So basically you'd give them 13 units with breakfast to cover breakfast and dinner, and 6 units with dinner to cover dinner and overnight. It's not good for patients with poor PO intake or variable PO intake. So this is kind of like a sulfonylurea, where if you take it and don't eat, you're going to drop. So it works well for people who are going to be consistent with their food, who are non-compliant with everything else, and you kind of don't have a choice. And honestly, it's better to get somebody to take it than not take anything at all. So this is why we kind of convert to this a lot of the time when patients are like so ridiculously non-compliant. You might as well just try this because, you know, it's better than them taking nothing. So I'll cover this real quick. Continuous glucose monitors, they're becoming super common. And so you're probably going to start seeing them more, especially if you're in primary care. But first of all, they don't deliver insulin. So I've had a lot of residents ask me this before. They're like, oh, they're wearing this device. Well, it's not a pump, it's just a monitor. And so it's used to monitor their blood sugar continuously without finger sticks. They work great. It's really nice that the patient doesn't have to prick themselves all the time. Most insurances will cover these if the patient is checking their blood sugar 4 times a day. So basically they need to come see you and you need to document in your note that the patient's checking 4 times a day with readings, because a lot of times the insurance will request your notes to back up the prescription. And sometimes if their insurance approves a CGM, they might not cover a regular meter. So if that's the case, you might want to just tell the patient to get a backup meter over the counter. The cheapest one is always RelyOn brand at Walmart. And Freestyle Libre and Dexcom are the most common ones of these. Freestyle Libre you have to actually like scan the sensor to get your reading. Dexcom, the patient actually has a continuous reading on their phone or reader that they use. And Dexcom is great because it gives you alarms when you're going low or high. And so Dexcom is best for like type 1s and patients that are really sensitive, or they have hypoglycemia unawareness. So sometimes when patients have been diabetic for a long time, they don't have symptoms when they're going low, which can be really dangerous. And so the Dexcom with the alarms is really helpful. The new version of Freestyle Libre, it has alarms, but you still have to scan to get your reading. So for the patients that are really sensitive, I'd still go with a Dexcom. But both of them work great. And it's a really good tool to have if you can get it for your patient. Eversense is one that I've never seen. It's implantable and it's not common. And then Medtronic has a sensor that goes with their pump system, but it's not for use without the pump. So you really won't see those either. A lot of these you can prescribe through their pharmacy. Some patients have to get it through a DME company though. But a lot of times it'll be covered now through their pharmacy benefits. And then insulin pumps are wearable insulin delivery devices. The most common brands you'll see are Medtronic, Tandem, and Omnipod. With these, the provider programs their basal, prandial, and correction settings into the pump. And the one thing to know about this is that the patient, it's not simple. So some people are like, oh, I want a pump, that'll be easy. It's not easy. The patient needs to learn how to carb count because every single time they eat food, they have to put the amount of carbs that they're eating into the pump. And they also have to check their blood sugar all the time to put their blood sugar into the pump. So, you know, if they're not going to put in the work, this isn't something that you would put them on anyways. So something for them to know if they're like, hey, can I get an insulin pump? Be like, well, it's not easy. So let's talk about it. And they really have to be on a stable injection regimen before you start them on a pump to make sure you know what they're going to need while they're on the pump. And they also need frequent paperwork with insurance. It's kind of annoying. And then writing prescriptions. So for all non-insulin medications, you're always going to start at your lowest dose and titrate slowly. GLP-1s and metformin we talked about cause GI upset. For insulin pens, so all U100 pens, which is most all of the insulins, except for those concentrated ones, they all come with 5 pens per box. Pharmacies really don't split up boxes. So even if a patient is on such a low dose that they could use 1 pen and it would last them a month, you still have to give them 5 pens at a time. Each pen has 3 milliliters or 300 units. So there's technically 1,500 units in each box. So if you're prescribing insulin, you're going to take your total daily dose and you're going to multiply it by 30 for 30 days worth, so months worth of prescription. And you'll divide it by 300, which is per pen, and that'll tell you how many pens you need for a month. If you need more than 5 pens for a month, you'd order 2 to 3 boxes at a time, just depending on how many you need. And so when you write the quantity in the prescription, you'll write either 5 pre-filled pens or 15 mLs, which just means give them a whole box. If you wanted 2 boxes, you'd say 10 pens or 30 mLs. For insulin vials, all vials are 10 mLs or 1,000 units. So there's more in a vial. And you use the same calculation. So your total daily dose times 30 days divided by 1,000 units to see how many vials you need for 1 month. And then if you're ordering pens, you always need to order pen needles. If you're ordering vials, you need to order syringes. So this is like all the supplies stuff that people overlook because, you know, a lot of providers will just provide insulin and then no supplies to use it. And then if you need to order a meter for somebody, you can just write a generic glucometer prescription. So you can just write a prescription for a glucometer and write in the comments, choose based on insurance preference. And so if you're ordering a meter, you have to order the meter, strips, and lancets. And then, like I said, just put in the comments, choose based on insurance preference. And then when you're ordering short-acting insulin, so Novolog, Admelog, Humalog, the pharmacy wants an estimated TDD. So basically you just round up somewhere close to what they need. So their prandial times 3 plus some scale coverage. So like if somebody's taking 5 units with meals and they have a correction scale, you would just say like total daily dose 30 units. So basically just kind of gives them an estimate of how much the patient needs, but it doesn't have to be exact. And then just some special considerations. These are just things that most people don't know. Patients on dialysis usually will completely reduce or eliminate their need for insulin or medications. It's pretty interesting. So once they start hemodialysis, all of a sudden they feel like they don't have diabetes anymore. But then if they get a kidney transplant, their diabetes shows back up. So just something to know. And then if a diabetic patient is started on steroids, they will always need adjustment. And this includes cortisone joint injections. So it's so common for orthos to give these patients joint injections and not tell them it's going to affect their blood sugars. So sometimes patients will come in and they're like, my blood sugars are crazy. I don't know what's going on. And you ask them what's been going on. And they're like, well, I got an injection in my shoulder and it's from that. So it doesn't always affect everybody the same, but generally steroids equal high blood sugars. And then, like I said, don't forget about mixed insulin. Patients can actually get 70/30 vials and pens over the counter at Walmart. This is a safety thing, and I tell it to type 1s because I have had type 1s run out of insulin and not call me and just not take insulin and end up in the hospital in DKA. And so it's something good to know that they can literally go to Walmart without a prescription and buy mixed insulin. So it's just something to know. The vials are usually $25. I think the pens are like 40 or 50, but there's more pens in a box than one vial of insulin. So it kind of evens out. And then something else interesting is that patients that have a gastric bypass surgery typically completely eliminate or dramatically reduce their insulin requirements like immediately post-op. This is an incretin effect situation. It's pretty cool. They'll come in with 3-4 agents for their uncontrolled diabetes and like immediately post-op, they're on a sliding scale or nothing. So that's really interesting, even before weight loss. And then if you're starting a new non-insulin medication and the patient's already on insulin, you might want to decrease their insulin by 20%. This is just a thought. So if you've got somebody on insulin and some PO meds and you want to start another like GLP-1 or SGLT2, you should probably decrease their insulin just a little bit so that they're not going to go low at the beginning. But those are just kind of some extra things. And that's it. So I know that was a lot of information, but that's why I will definitely send you guys a recorded version of it. Any like questions that you thought of while I was talking?
What kind of patients do you, I'm sure it's a big question, but like what kind of patients do you anticipate or recommend specifically for FNP or primary care to refer to endocrinology?
So type 1s, I mean, really you can refer any type 1 to endocrinology because honestly, they're complicated and it's a good idea for them to have an endo. And then if you have any concern that they are pancreatic insufficient, so if you have a type 2 you've been managing for a while and they're showing any of those signs of pancreatic insufficiency, or they have an episode of pancreatitis or something like that, you can refer them. But it would be nice if you get a C-peptide first to assess them. That would be like a big gold star. And then let's see, just you can always refer a type 2, but I wouldn't refer a type 2 until they're like, you really feel like you've tried everything. And just pregnant patients. If you've got a type 2 or a type 1 that's pregnant, I would probably refer them.
I have a quick question. I have a patient who is on 1,000 of metformin daily, and it really does really well controlling his diabetes. However, he does have the diarrhea problem.
Mhm.
And, I'm hesitant because he's, so controlled on that to really mess with it. But what would be your suggestion?
Sure. Is he on immediate release or extended release?
Immediate.
Okay. So, and it's only 1,000 once a day so far?
It's supposed to be 500 twice a day, but really and truly, the patient takes 1,000 at once every night because he forgets to take the 2 doses. So,
Okay. So two options or a couple options. Number one, make sure he takes it with food.
okay.
If they take it on an empty stomach, that makes it worse. Number two, change it to extended release. And you can keep it 1,000 once a day at night, extended release, and that might be better for him.
Okay.
Or you can encourage him to split it up, 500 in the morning, 500 at night, but do extended release instead of immediate release. That's
Okay.
probably what I would do for him.
Okay. I will definitely try that. Thank you.
Hmm. Yeah, and metformin is so great because it's so cheap.
Yeah,
And so it's like, I don't want to really, put you on something else that you can't afford if metformin works and it's just giving you diarrhea.
definitely.
Yeah. Anything else?
I do have one other thing. So I
Yeah.
feel like I've got a lot of scenarios of my different patients with different issues. But if I specifically go through their charts, and because I want to be able to have like pull their very specific information, I have some that are pretty complicated and a little hard to control.
Hmm.
Can I message you personally? And
Yeah,
okay. All right. I have like a handful of them that I've really been trying with, but there's
sure.
so many, there's so many, things in the equation, even mental status and things of that nature that I'm kind of dealing with them. So
Yeah,
it's really been a challenge, but it's really been, a learning process for me, and it's very interesting. And I'm really glad that you had this segment
sure.
today. So thank you.
Yeah, no problem. I completely understand too, because diabetes is crazy. Like, I mean, even when these patients are seeing us in endocrine, we have trouble controlling everybody because it's so complicated. And not only is it complicated, but patients aren't going to do what you want them to do. And they just don't care. It's really interesting. So it's like some of them, when they're really motivated, it's amazing. But like a lot of them, you can put them on the perfect regimen, and then if they don't do it, it doesn't matter. So sometimes you have to maybe put them on a regimen that's probably suboptimal overall, but it's going to work better because they're going to actually do it. So,
Mhm.
and like I said, in a lot of these things, there's so many things to consider. Like, are they not eating frequently? Well, then you don't want to put them on glipizide, or you don't want to put them on mixed insulin. Are they old and falling? Don't put them on glipizide. Like, there's just so many things to consider with all of these meds. And so, yeah, I'm happy to answer questions, and it's totally not something to feel like you have to be an expert in, because it's rare that anybody is.
Yeah.
So, so I pre-recorded a session of this, so I would already have a recorded version, but I recorded this one too. Would you guys rather I